All right, here we go. Kinesiology 230. This is chapter 22. We're talking about clients with spinal cord injury, MS, epilepsy, or cerebral palsy. This is presentation number 1, and we'll get into an introduction and spinal cord injury. When we get into this, I'll let you go ahead and read through this list and we start talking about learning outcomes. But I have to state this. If you're going to work with clients who have spinal cord injury, MS, epilepsy, or CP, you're going to be pretty highly specialized. So I'm working under the presumption that we have to go over kind of a topical overview, hit the bullet points that the book is looking for, some of the quiz questions. And when you get into the industry, if you so choose to specialize, then you'll go off and do some additional research and also pick up maybe some additional certifications in these specialty areas. But make no mistake about it, working with this population is a highly specialized population requiring highly specialized skill. So they go into spinal cord injury and they talk about the different segments of the spine itself. And they note that when you have an injury at the highest point of the spine, which is the cervical region, there's an injury, say at C1 or C2, that will affect everything else downstream. So when you have an injury further up in the spinal column, it'll affect more things further down. Meaning, if there's an injury to the neck or the cervical area, more than likely the person that comes in will have quadriplegia, or another way to say that is tetraplegia. And if you think back to when we were talking about the 4 tops and the hemoglobin, that terminology for that was a tetramer, 4 tops. 4, tetra, I believe it's French if I remember correctly. So tetraplegia, tetramer, just different areas of the body and using the verbiage a little bit differently. So we know that the higher the injury, the more of the body that will be affected. And the book notes that injury to the thoracic segments, T2 to T12, will cause impairment in the trunk, legs, and or pelvic organs in paraplegia. So think para, 2, tetra, or quad, 4. And they go a little bit further into this in terms of like the higher level of the injury, the more extensive results. But usually the best way to see this is a dermatome example, where if a person has an injury in C1, C2, it's going to affect everything else downstream. If a person has an injury, say in T9, they're going to have the injury is there in the low back, in the lower part of the thoracic region, upper part of the low back region. What ends up happening is the nerve root itself affects everything else downstream. So, we're talking about the actual regions of the spine and also the dermatomes that are affected. So it looks a little bit different than what you might see in terms of cervical, thoracic, lumbar per se. Down here, it's the dermatomes on the skin. So when you look at this, when a person has, say, numbness in their pinky of their right hand, you can pretty much narrow it down to some type of dysfunction somewhere between C8 or T1, right? Cervical 8, thoracic 1. Doesn't mean it can't be somewhere in the brachial plexus over here. That could happen, but you can usually narrow it down to that. If a person has numbness or tingling or an issue with their big toe, well, that takes us to L5, S1, perhaps S1 or S2, which is further down in the spinal column. So the point I'm trying to make here is when you have injury in the actual spinal column itself, sorry about that, in the injury in the spinal column itself, it affects everything else downstream. But because of the nature of the dermatomes and the dermatomic system, it also provides a little bit of roadmap to where dysfunction may be. So a client might come in and say, yeah, I have this numbness and tingling going down the inside part of my calf. You should start thinking in your head to L3, L4. Maybe there's some kind of issue going on in there, and you can ask well-informed questions of your client to say, have you ever had a low back injury? Do you have anything going on with your low back right now? And they might say, well, yeah, I have a little bit of discomfort in my low back, and they might point to like the lumbar region of their back. You, after hearing that they have some numbness and tingling going on the inside part of the calf, might look at that and go, well, it's probably going to be L5, S1 is where the injury is or the issue is. Then you can go into other conversations about what they're doing. Okay. Clinical manifestations. When they talk about spinal cord injury, that's SCI. They switch to SCI here instead of writing it out. There's many different manifestations that come about, but they talk about dysrhythmias are increased. They also talk about, for example, the higher the lesion or the higher the injury, like, when you look at like above T3 and T4, these individuals are going to be prone to bradycardia, a slowing of a heart rate, cardiac arrest, and other cardiac disturbances. Now, they do provide a list over here, and I'll bring it up in a second, but they spent some time referencing autonomic dysreflexia. And it's the disruption of the neuroregulation of the arterial blood pressure. And when you have an injury above the T6 level, usually they're quadriplegic, and it again affects everything downstream. So if you have an injury that high up, it's going to affect everything downstream. And to a certain degree, the systems that affect heart rate and the systems that affect blood pressure will also be affected if there's a spinal cord injury. So your list starts right here: orthostatic hypertension, and then it goes into autonomic dysreflexia, and then from there it goes into a bigger list over here. So you can just kind of take a moment and just kind of pause and read through some of these and kind of commit them to memory. But then you get to autonomic dysreflexia. And they go into autonomic dysreflexia. AD is a spinal cord injury that disrupts normal regulation. Normal. Sorry, go back one. Normal neural regulation of the arterial blood pressure, particularly in the persons with tetraplegia and lesions above T6 level, which we already know. So the autonomic dysreflexia AD can be life-threatening. You need to actually communicate with your clients on the front end and kind of run a little workout check. Do you have a headache, blurred vision, any kind of anxiety? And the book knows that just for incontinence purposes, you'd like to have your clients use the washroom before they come in and work with you, which kind of makes sense. But what they note, and it's for later, is diastolic blood pressure should be back to baseline within 15 minutes after recovery from exercise. And if it isn't, then you have a whole other issue in terms of autonomic dysreflexia. Now the thing is, they go into boosting, they go into a little bit about performance enhancement here, and this is kind of outside my scope of practice, and I'm not 100% sure how I explain this to you, but the way it sounds like is with boosting, you have a situation where your client is a maybe competitive wheelchair basketball player or a competitive tennis player, and they'll use this much like you would use a Valsalva maneuver to increase blood pressure, to have greater ability to push more weight around because you have interthoracic pressure, interabdominal pressure. Boosting itself is voluntarily inducing autonomic dysreflexia to improve performance. So it becomes almost like a doping type hack, if you will. So I would presume if somebody's using this type of technique, they're familiar with it, it might not be as dangerous. But I would say if your client is doing this, you probably have a well-informed conversation with them regarding this technique and the benefits of and the risks associated with boosting and causing involuntarily causing autonomic dysreflexia. All right, so the book provides some signs and symptoms of autonomic dysreflexia and triggers. In medical terminology, they get into precipitators. Precipitators, in medical terminology, is a factor that triggers or brings about the onset of a medical condition, just FYI. So maybe pause and take a read through some of these and be a little bit more well-informed on those. So with a person with spinal cord injury, particularly those with high lesions, like further up in the spinal cord, are unable to increase skin blood flow in paralyzed areas. This impairs the ability to dissipate metabolic heat and places them at increased risk. So you have to be kind of smart in terms of having fans for convection to blow heat off of your person. You need to be smart about working them out in a controlled environment that might not include outside in the summertime or outside in the wintertime. So these individuals are also paralyzed, and they lose not only function of the muscles, but they have a little bit of loss in the sensory side as well. So now you have a bit of a double whammy here. So they can't really dissipate metabolic heat, and they can't really feel the increase in temperature or decrease in temperature in the environment itself. Now, persons with spinal cord injury have poor venous return, particularly in the seated or upright posture, and this is due to lower limb venous pooling secondarily to lack of sympathetic tone and absence of the venous muscle pump. And we talked about this a little bit earlier in the lower extremities in terms of how blood is shunted through the body, and you have valves that allow that to happen. But part of the process of the pumping comes from the muscular contraction in the lower extremities. And if you have somebody who is paraplegic or even tetraplegic, but if they're paraplegic and don't have use of their lower limbs, they can't move their legs to cause the shunting of blood. They can't contract the muscles that actually constrict the blood vessels and help push the blood back to the heart. So you end up with a lack of the venous muscle pump, and so you'll end up with poor venous return and pooling in the extremities. And I know that's somewhere else. They go into this, and a person with spinal cord injury may not perceive ischemic cardiac pain. Other signs and symptoms like shortness of breath, excessive sweating, fatigue, lightheadedness, a sensation of fainting, and palpitations may occur. If any such symptoms is or are present, an exercise session should not be started or should be terminated, and medical follow-up should occur as soon as possible. So I know there's a two-part question where you have to talk about the actual medical follow-up. So the big thing is there's that loss of really the perception that they're having any kind of like cardiac pain. They might not realize it. It might manifest in other cardiac related symptoms. And if a person is having an MI, myocardial infarction, and they are tetraplegic or quadriplegic, they might not realize it. So you just have to be aware of some of these secondary symptoms. That would be the shortness of breath, the excessive sweating, fatigue, lightheadedness, etc., to be able to recognize if that person is in fact suffering from a heart attack. So based on the type of injury, resting metabolic rates among people with spinal cord injury can be 14 to 20% lower, and this is likely due to the less overall musculature and decreased activation of the sympathetic nervous system. So it kind of makes sense in terms of you don't have function of part of the body, so as a result, you're not using those muscles, and as a result, those muscles then don't have to be serviced quite like they would be if you were up walking around all day. So long story short, what you see is, the basal metabolic rate, the BMI or resting metabolic rate as noted here, is lower. And this will be seen later on, but when you look at this, the more you can get your person to move around, the better. And they note here with spinal cord injury populations, as with other populations, there's a strong relationship between physical activity levels in both VO2 peak and upper body muscle strength and endurance. So the idea that a person is injured, they can't do anything, they're just going to sit around. If you get these folks moving, they can show that people with spinal cord injury have 13 to 23 and 16 to 22 greater maximal cardiac outputs and stroke volumes, respectively, than their sedentary counterparts. So whether it's spinal cord injury or other injuries, as we'll see, if you're able to get your people moving, you'll see demonstrative results. So that's kind of your key takeaway. They do note that forced vital capacity, a total volume of air forcefully exhaled, is reduced by 50% in persons with high tetraplegia, meaning further up there's an injury. They talk about hyperkinetic circulation here. They don't really highlight it anywhere else later on, but it's something where you probably want to take a moment just to read through this and get a little bit of an understanding of hypokinetic circulation. Hypo meaning low, kinetic meaning movement circulation. And the idea that you have the upper body vasodilation, right? So as you're working, maybe you're doing upper body ergometer and you're moving your arms, the vasculature will vasodilate in the upper body, whereas the lower body will have vasoconstriction because you have a shunting of blood to the muscles that are being used. This reduces the central circulatory volume, right? And the shunting of blood between the different sides of the body is the dysfunctional system there is referred, or syndrome is referred to as hypokinetic circulation, so low kinetic circulation. And the low kinetic is in reference to the lower body not actually moving, where the upper body might be doing the upper body ergometer, the lower body is just kind of there. So it's recommended that blood pressure and RPE be monitored throughout exercise because heart rate and blood pressure can be affected by these commonly prescribed medications. And they list these medications earlier, but they're not something you're going to have to reflect upon. And with that, take a look at some of the tables that are on these two pages, 22.1, 22.2. They're just awkward in how they would have to be printed out here. And with that, I'm going to break off and go to the next presentation. Thanks, guys.